My name's Emer O'Connell. I'm a consultant in public health with Public Health England, and I'm going to talk to you today about health and climate adaptation. So I'm going to use two examples from the risks that we manage within the team, and this is the health risks of heatwave and the health impacts of flooding. And these risks have been identified in the climate change risk assessment as important and needing more action. And they're two of the key risks that my team manage on behalf of Public Health England and the Department of Health and Social Care. So starting first with heatwave deaths, well, this gives an example of the sort of mortality or excess deaths we see across the summer period. This is the summer period of 2019, and you can see here that the green line is the Central England temperature, which had two little peaks here and here, and correlating peaks in excess all-cause mortality. So you can see here that over the course of the summer, there was approximately 900 additional deaths that occurred as a result of heat wave events. So it's important to note that these are not deaths that would have occurred anyway. There is a bit of a myth around that. We know from the epidemiology that's not true. Some of these deaths might have been pushed forward a little bit, but the vast proportion are not deaths that would have occurred anyway, and are largely, these are preventable deaths. The type of people who die, and we know that the risk factors are the over 65s. So this black line is specifically a death of the over 65s. We know that if you have a comorbidity or if you have a number of existing health problems that you might need to deal with, such as lung and heart conditions, that would also increase your risk. And there's also an element of cognitive ability. So if you are unable to adapt yourself, your behavior, your environment to the increased heat, then that also puts you at risk. So where do these deaths happen? Well, I wouldn't pay too much focus to the detail here, but what this is really saying is that across all of the regions in England, in these two heat wave events, deaths occurred pretty much everywhere in the country. And usually we see heat events where London and the southeast and maybe a little bit further north get very, very high temperatures. But this shows you that the deaths can occur even as far north as the northeast, which, relative to everywhere else, has fairly cool temperatures. So although the temperature mortality relationship itself drives much of this impact, there are many other factors that are involved, and those relate to behavioral factors, housing, and so on. So just to use this to illustrate, it looks complicated, but I will explain it. And it demonstrates a really important feature of a classic public health problem where you have an emergency response function that needs to address the health impacts of the extremes, and then an underlying prevention requirement, which requires focus on the structural determinants of those health outcomes. So the x-axis here shows the temperatures. The bars here show the distribution of temperature days, so the proportion of days at each temperature. So you can see most of the days in London are around this sort of medium mark. And this line shows the relationship between temperature and an increase in deaths. So you can see that from a fairly low threshold here at 24 degrees, as the temperature goes up, deaths start to go up. And when you get to around here, just underneath 35 degrees or so, you'll see that an increase of around 30% to 40% of deaths during those days. But actually, these days don't happen very often. They're quite rare, thankfully. But what does happen is there's a whole lot of days here where you're above the point at which harm starts to occur. You're below the point at which your alerting kicks in and your emergency response function kicks in. But actually, there's quite a lot of harm happening here. And this is due to the relatively high frequency, low impact days, relatively low impact days, of which there are a large number. So overall, we know that by far the greatest burden is here. And how you address this burden here really links us back to the idea of adaptation and resilience in the population. These deaths are ones that could be preventable, but are far more difficult to prevent because you're not in this emergency response function here where, health services, social care are going out knocking on doors. This is about other things. This is about housing, it's about community cohesion, it's about individual resilience, physiological vulnerability, all of those other things. So I mentioned there our emergency response function, and we know that we have a good heatwave plan for England. We know that our alerting system, people pay attention to it, it functions very well. And the consequence of this is that if you look at this bottom graph here, Big heat wave of 2003 when lots of people in Europe died. The heatwave plan was introduced in 2004. A lot of awareness raising, introduction of the alert system around here. Big heat wave in 2006, quite a lot of mortality related to heat wave days, but then over time, this has gone down quite a lot. So this is only deaths related to heat wave events. So this is showing us that our heat wave plan, our emergency response function has actually been quite effective. But actually, since 2003, we've started to see this go back up again. So what do we need to do to address some of those underlying factors when we're outside of that alerting period? And what's driving that recent increase in deaths during those heat wave emergencies? We know that housing is a really significant modifier of the risk related to heat, and indoor overheating is a significant problem in England. It's very hard to quantify, but we do know that it's happening, and that many of the people who die during heat waves die in their own home without ever accessing healthcare services. We have a growing population who's getting older with managing multiple comorbidities. That means they'll have multiple health problems, all of which make them at higher risk of a heat wave related death. And we also know that the way the care is being received in the community is changing. So you can see here since September 2010, there's a reduction in the number of people in residential homes and a concurrent increase in the number of domiciliary care agencies providing care. So you can see here that people are being encouraged to live independently in their house for longer, but with a bit of help, maybe quite a lot of help at home, but fundamentally people are at home. And in the meantime, the amount of funding being given to this domiciliary care has also been decreasing. So we're getting a perfect storm here. We know that the exposure is going to increase because of climate change. We know our vulnerability, our core vulnerability is going to increase because of an aging population, managing multiple health problems. And we know that our resilience is reducing because the amount of care being provided is also reducing. So on to flooding. Well, we knew that we had really significant impacts from flooding, from all of the flooding events that we'd experienced, but we found it very difficult to determine to quantify those health impacts, because we understood that whilst there was an immediate risk to life during the heatwave event, we could also see that many of the impacts on those communities were very prolonged and focused on mental health impacts. So the cohort study of flooding carried out in England was done in 2013, and this provided us with the evidence that we had always suspected the health impacts related to flooding would reflect, but this gave us the quantified evidence that we needed. And this demonstrated that there were very significant impacts on mental health quite some time after the flooding events. So people who were directly impacted by flooding were approximately 6 to 7 times more likely to have depression, anxiety, or PTSD a year on than those not affected by flooding. But one of the other useful things this cohort study was able to confirm was that you don't need to have floodwater in your home to be affected. It's enough to be disrupted by the flooding event to have significant mental health impacts for quite some time afterwards. So the example down here is that those who are disrupted and lost access to health and social care were 10 times more likely to have PTSD. These are really, really strong associations with that extreme event. But when you think about how those mental health impacts occur, this is a classic case of where the secondary stressor is driving those health impacts. And so when you think about mitigation and interventions there, this really goes back to resilience and recovery of populations and those other things, those structural things that society can provide. It's not always just about health services. So these are things like education and schooling, social cohesion, living close to your family. Loss of physical possessions and resources is a really significant one for people who've been flooded. So this gives you some insight into the interventions that are required outside of the health system itself. So inside of the health system and the health service, there is a lot of focus on climate resilience of health systems, and the WHO has provided a very useful framework around which we can understand how well prepared we are. But it is always important to remember that this is only one part of the health creating system. Health services can support and are often there to mop up the problems, but actually where you prevent the problems from happening is in the communities you live, access to a stable income, access to safe and secure housing, communities, schools, all of those other things, which we all know help us to live healthy and happy lives. So what does this mean for adaptation in the long term, and what when I think about resilience in the UK, I have in the past often focused on some of the things we see during heatwave events that tell us about the gaps in the system. We had long identified social care as being very fragmented and not helpful during heatwave events, but COVID has really highlighted some of these vulnerabilities. And I think that moving forward, when we have time to look at where these deaths happened and why we saw so many of them in England, that will tell us a lot about where we need to focus our efforts in terms of building resilience. So in particular, you can see from these ONS data that this is the peak for the COVID deaths across the spring, but actually we had a really, really large number of non-COVID all-cause deaths that were in excess as well. And this tells us a story about behaviours, services, resilience in general. And when we tease apart what happened here, I think we'll have a lot of lessons learned about what we need to do to ensure resilient populations going forward. And our populations will have to be very resilient when it comes to climate adaptation. So the key challenges for health and adaptation is that the drivers for the health outcome itself are distal and diffuse, and local interventions are usually where it needs to happen. These drivers are things like individual vulnerabilities, housing, poverty. They're very difficult to address, and they're also very difficult to quantify and assign metrics to. So assessing their cost effectiveness is also very difficult. Health as a shared outcome ends up being everybody but nobody's responsibility, and people often use health as the motivating factor for a threat that might come to pass if you don't take action, or an opportunity that you'll miss if you don't take action. But actually it's very rarely included as a stated objective within policies, and we know from previous experience that the consequence of that is that these benefits are not accrued, and in fact they have quite a lot of potential for increasing health inequalities and potentially the burden on people who are least resilient to the consequences of climate change and least able to pay for the mitigation efforts as well. There's also the issue of the health services, the timing of how they manage their planning cycles and their response to threats. So they're very good at dealing with emergencies. We know that our heatwave plan resonates with NHS and other providers, but actually whilst they're focused on other things necessarily, COVID just being the most recent, it's very difficult for them to think in the sort of timelines that we're talking about here, especially when it maybe includes huge capital spend, such as making sure a hospital isn't overheating. And that is a real challenge here too. So that's, to sum up, really, it's a bit of a whistle-stop tour. My acknowledgements are really for those whose slides I've stolen to make my own into this. But if anyone has any further questions, feel free to contact the team on the email below. Okay, thank you very much.